So we know from many different studies that non-white women suffer from many of our gynecologic cancers, specifically cervical and endometrial cancer, disproportionately. And a lot of those cancers, particularly the cervical cancer, is about access to healthcare, because we can prevent cervical cancer, but if you can't access healthcare because of your various social resource needs, then you cannot access prevention to cervical cancer. So in our two abstracts, we're basically giving you the data from the implementation of the project that we did, as well as the kind of patient outcomes. The data we presented is just from our first 3 months of implementation of a social needs screening algorithm. So back in 2017, we essentially started handing out a paper-based screening to patients in order to figure out who has social needs and then refer them for resources. You really can't ask the question about social needs unless you have a plan to address those needs, because they're a pretty sensitive topic to ask people about, and it would be inappropriate not to have a next step. So in 2017, we started doing this paper-based screening. We figured out that a third of our patients have needs, but about 50% of people just weren't filling that paper out. So these two abstracts are basically looking at the first 3 months, where we integrated the screening into our electronic medical record, as well as into our just clinical workflow. So patients either did it on their online patient portal as part of the EMR, or they did it in the clinic with the MA if they hadn't done it ahead of the visit. And essentially what we found was about 20% of women had at least one need. Most women were desiring a referral to resources if they did have a need, proving that this was acceptable. We proved that it was feasible because 98% of people actually did this screening, which was much better than when we were doing paper-based screening. And we showed that all of these needs are significantly more likely to occur in women of non-white race, also unmarried women or women with Medicaid insurance. And so we have not yet looked forward to see how our intervention, providing resources for these needs, is going to affect their oncologic outcomes, but I think that's an important next step. The onus really needs to be on us as physicians and us as the cancer centers to take responsibility and introduce these questions with a plan for resource referral into our routine screening. We're already screening patients for distress, we're screening them for depression, and so this should be another standard of care. And I think that it's really tough. It seems very daunting, but I think each institution, you can look at what resources do we have? Do we have social workers? Do we have, financial assistance? And if you have some resources to refer people to, you can start doing the screening. And we are more than happy as a research team to, share the lessons that we've learned, as well as the actual instruments that we use to do the screening.